Yeah, it's live, I think. Yeah.
Yes, just a minute, ma'am.
Yeah.
A very good evening to all and welcome to the Clarinet session on infertility management, poor ovarian reserve. It's an honor for us to have Ritu ma'am once again with us. Ma'am is very familiar to all, but still a small introduction. She's a director at Pune Test Tube Baby Center and Shyam Well Women Clinic. Ma'am is an obstetrician and gynecologist, a cosmetologist, and an IVF specialist. So without doing any further delay, now I would request ma'am to please start with the session. Over to you, ma'am.
Yeah. Thank you, Arpita. Thank you, Clarinet team. Very warm welcome to all of my dear friends who have joined all across the geography. So friends, as all of you are aware that every Thursday we are having a session, the experts in conversation with Dr. Ritu or the icons in conversation with Dr. Ritu. So today, due to some unevitable circumstances, Dr. Salva Buckley is not able to join with us. So Clarinet team insisted me, no ma'am, today you have to take the session. So friends, I have just recovered from very bad health. So within a day, I prepared this talk regarding the poor responders. So I think every one of us getting the patient of poor responders or the poor ovarian reserve. Actually, these two are the different entities. The poor ovarian reserve may be a good responder, or maybe a good ovarian reserve patient may be a poor responder. So I have tried to make this talk as simplified as possible, and I have given the emphasis on the medical treatment what we can give. Reminding you, the dear friends, that in this this talk, I emphasize the use of the drugs, not the costly gonadotropins, growth hormones, the other things which the normal gynecologists are not using. So this talk is open for all, for the discussion, for the gynecologists also, for the IVF specialist also, but I focused mostly on the medical treatment. So now without making delay, I'm just starting sharing my screen. Meanwhile, if any of you have any questions, so all of you are warm welcome for that, for the discussion. So just after finishing my presentation, we can, what happened now? We can go for the discussion. My screen is visible, no?
Yes, ma'am, we can see your screen. We can see the Facebook page, ma'am.
No.
You can minimize this one and
yeah.
Into the video.
Yes, and I will again share. Yeah. Actually, yes, I think now it is. I'm making it full screen. Oh, what happened? Sometimes it takes some time. Just a second. Yeah. Yeah. So, dear friends, a very, very warm welcome. As all of you are aware, my every presentation will start with Stuti to my goddess Durga Mata, as we have just gone through 2 bad phases of corona and still we are fighting with the corona. Every day we are seeing a lot of cases of the corona of Omicron. So my prayer to my goddess Durga, Ya Devi Sarvabhuteshu Chikitsa Rupen Sansita Namastasei 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 Namo Nama. So namaste to my all dear friends and salam alaikum to all of my friends who have joined all across the geography. I'm able to see so many of friends have joined from the Gulf countries and the Egypt too. So today, this talk will be dedicated to my very great friend, Dr. G.K. Tripathi. Today, exactly the 2 years have passed when we have lost him. So GK, wherever you are, you will always be fondly remembered. We can never forget how he inspires everyone and how humble he was. So GK, my this talk is a tribute to you. So now I'm going to discuss regarding this infertility management in the poor ovarian reserve patients. So now, what's the new line of management in the patients with diminished ovarian reserve and the premature ovarian aging? So what are the challenges we face in the treatment? So as we all know, the patients with the diminished ovarian reserve faces a lot of difficulties in getting the conceiving. So now what is this diminished ovarian reserve? Diminished ovarian reserve is defined as a decrease in the number of quality and quantity of oocytes affected by age, genetics and environmental factors, and DOR is irreversible. Women with DOR at risk of poor ovarian response to ovarian stimulation in ART. It is distinct from menopause or premature ovarian insufficiency. So friends, here we can see the serum FSH levels normally less than 12 international units per ml. In poor ovarian reserve, we are able to getting more than 12 international units. Similarly, the AMH less than 1 nanogram and AFC count less than 5, which is normally should be more than 10 per ovary, and serum AMH normally should be 2 to 4 nanogram per ml. So now coming to this poor ovarian response, the poor ovarian response implies a subnormal follicular response, which means less number of eggs retrieved after ovarian stimulation during IVF. According to each definition, the POR using the Bologna criteria in order to standardize the definition. So, friends, here we can see at the birth, there are almost approximately 1.5 million of the egg supply. While coming up to the puberty, it is reduced up to the 23%, around 345,000. Then at the age of the 30 years, you can see around 12%, 180,000. While at the age of the 40, it's around approximately 45,000, 3%. So this is the premature ovarian failure. So, according to this Bologna criteria, the poor ovarian response, the two of the following three features must be present. The advanced maternal age, more than 40 years, or any other risk factor for poor ovarian reserve. A previous ovarian reserve, less than 3 oocytes with a conventional ovarian stimulation protocol. An abnormal ovarian reserve test ORT, antral follicle count AFC less than 5 to 7, or serum AMH level less than 0.5 to 1.1 nanogram per ml. Friends, again here mind here what the I am taking the giving the values of AMH in the nanogram per ml. So we all aware about this criteria. For this, the group 1 we have seen the age group less than 35, AFC more than 5, AMH 1.2, more than or equal to 1.2. And in this, again, they divided the subgroup. In the 1A less than 4, and in the groups 1B is 4 to 9. While coming to in group 2, they have taken the age group has come is more than 35. And again, group 2 and group 2B again less than 4 and 4 to 9. While in group 3, again they have taken the AFC is less than 5 and AMH less than 1.2. While in group 4, again they have taken the age group more or up to 35 and AFC less than 5 and AMH 1.2. Sorry. Just a second. Just. sorry for this. Yeah. So, just a second. So, as we know here, now what are the pathogenesis in this poor ovarian reserve? What are the factors which are constituting? As we all are aware, the advanced reproductive age, smoking, very common in the metro cities, family history, fragile pre-mutation carrier, previous ovarian surgery, history of therapy, chemo or radiation, conditions that may cause again the ovarian injury, either the excessive cauterization used at the time of the ovarian cyst or the endometriosis surgery, or the genetic conditions, 45X or mosaicism. Now, the diagnostic parameters for this ovarian reserve test are the biological, biochemical, and biophysical. Among this biological, friends, we have seen the chronological age in the biochemical FSH more than 12 international units per liter or AMH less than 0.5 to 0.9. Among this biophysical, the USG AFC less than 5 and Doppler, the ovarian blood flow. Now, according to ISHRE guidelines, in accordance with ISHRE consensus, the patients with reduced ovarian reserve should be defined as expected poor ovarian responder to ovarian stimulation. So now what are the problems in the patients of the diminished ovarian reserve and poor ovarian reserve? First, the poor and depleting follicular reserve, mitochondrial dysfunction, reduced blood flow to ovaries, high level of the free radical damage, correlation between the poor ovarian reserve and outcome of pregnancy. So friends, here you can see the decreased embryo quality with advancing age and decrease in the spontaneous fecundity with advancing age, decrease in the oocyte numbers, or we can see decrease in the embryo numbers also, decrease in the pregnancy rates with infertility treatment in general, and increases in the aneuploidy with advancing age. This poor ovarian reserve leads to a poor outcome of pregnancy mainly because of two factors: decreased level of intra-ovarian androgens, oxidative stress due to reactive oxidative species. This all has been supported by the Journal of Endocrinology. So now how this oxidative stress affecting the fertility? Because these days when the patients are coming to us in our OPD, lot of young patients are coming with a diminished ovarian reserve and patients are not ready to go for the donor egg. So first we are trying with all the medical treatments. Yes, of course, that all depends what are the other conditions and no other comorbidities. So in oxidative stress affects fertility, the free radical function in microenvironments of oocytes and in follicular fluid. Changes in these microenvironments directly impact the follicular development, ovulation, quality of oocytes, sperm-oocyte interaction, implantation, and early embryonic development. So, this oxidative species damages the oocyte. So, friends, here we can see physical and chemical stimulation by aging, reactive oxygen species, again at the time of the ovulation process. This increased oxidative stress, decreases the mitochondrial activity, ATP synthesis decreases, antioxidant enzyme activity decrease, chromosomal damage increases, then follicular atresia, then which causes the number of follicles decrease, ovarian reserve decrease. It will accelerate the oocyte aging and oocyte quality decreases, infertility, abortion, and DNA abnormality. So now what is the management of oxidative stress? So friends, as we are aware of the lifestyle modification, in this the quitting of the smoking, stop the alcohol intake, manage the weight, and antioxidants, the melatonin, vitamin C and E supplements, coenzyme Q10 and DHEA. We all aware about of this regarding this DHEA every day one or the other company person is meeting us regarding the use of DHEA. And now there are a lot of studies are there for regarding the use of coenzyme Q10. And we are getting very good result with this. When I've gone to NUHS Singapore for my IVF training, there I have seen they are prescribing coenzyme Q10 in every patient of the IVF, in spite of this AMH. So having a very, very good results. Yes, vitamin C and vitamin E supplements, and of course the melatonin also a lot of studies are available and having a very, very good results. I myself is using in so many of my patients melatonin and very good results with that. So as we have just discussed, the smoking and drug abuse. Alcohol also, take these two slides on a lighter vein. So now how to manage the Ujjwala ma'am, I will give your answers. Just go through the slides. Yeah, I have mentioned everything in my slides. Yeah. Yeah. So regarding the management of diminished ovarian reserve and poor ovarian reserve, so this adjuvants in ART to increase the response, improve the ovarian mitochondrial function, improve the blood flow to ovaries, not addressed till today by available options, and free radical quenching. Now why screen sharing is paused? Yeah, yeah. So as I already mentioned that today my talk will be focused on the medical treatment. So the role of leucine in the management of the poor ovarian reserve patients. So these are the some new amino acids. New studies have come regarding the use of this amino acids in the poor ovarian reserve patient, and getting a very, very good results with them also. So just okay, just a second. Lot of studies have come regarding the use of mTOR to several human diseases, including cancer, neurodegenerative disorders, and aging. Studies have shown that the cellular metabolism comprises the foundation of all biological activities, including the female reproduction. And recently, accumulating the lines of evidence have shown regulated processes are important for folliculogenesis, oocyte meiocytic maturation, ovarian somatic cell proliferation and steroidogenesis, puberty onset, ovarian aging, endometrium changes, and embryonic development. Here, the rapamycin is a macrocyclic lactone which is produced by the bacterium Streptomyces hygroscopicus, which was previously used as antifungal agent but abandoned because of its immunosuppressive effect. The protein target of rapamycin TOR was originally discovered in genetic mutation studies using Saccharomyces cerevisiae and subsequently to be the target of rapamycin FKB12 complex in the mammalian cells, which is now referred to as a mammalian target of rapamycin mTOR. So now how this is acting on the primordial follicles, pregranulosa cells, and oocyte, and how it helps. This is the mechanism of action. This mTOR signaling acts in the folliculogenesis. During the folliculogenesis, the primordial follicles develop primarily to pre-antral, antral, and pre-ovulatory stages, and finally able to release an oocyte for the fertilization, primordial follicle activation, which is the beginning of the follicular development after puberty, determines the ovarian reserve and reproductive lifespan. mTOR signaling is involved in these changes. So this is the path chart of that. I don't know why my screen is getting paused. I'm getting some messages. Are you not able to see the screen?
Ma'am, we can see.
We can
Can
see.
you please go on to the next one?
Just see, I got some messages constantly. My WhatsApp is that slides. Huh? See?
Ma'am, the slide that I'm able to see is management of DOR and POR.
Yeah, correct. Same,
Okay.
huh? Now see, please, I'm moving this.
No.
You're not able to see?
No.
Leucine acting on the friends, please write it. No?
Ma'am, I would request you to stop sharing and share it once again.
Wait, yeah. I will share again.
Yes, ma'am.
So I have to go down. I don't know what happened. Clicking in this only, making it full. No, I want this. No, I want this one, no, 31. Okay. Now, Arpita?
Yes.
Let me move and please revert me. See?
Yes, it's moving, ma'am.
Yeah,
I can see a graphical representation now.
Yes, graphical representation. Yeah. So, how this leucine is acting? So, sorry, again, I have a very bad throat. So this actually is showing how the mode of the action. It is actually the biochemical action slide. So let me move to other. Yeah. So how this slide is acting, how this mTOR is acting on the different receptors. These two slides showing the mode of action of that. So now the studies have been presented. These studies have been presented on the April 2020 from this reproduction and fertility, the mTOR pathway in reproduction from gonadal function to developmental coordination. So there is a study presented by Biabina Korea and Maria Inuslusa regarding the use of this drug. So how this mTOR is acting in the oocyte meiotic division. So a lot of studies have come that mTOR C1 acting on the spindle morphology chromosomal alignment, and mTORs on the C2 receptors with a small GTPase acting on the actin cytoskeleton. Then it helps in the post-fertilization events also. Then the studies have come mTOR in the primordial follicle activation, elevating the mTOR in primordial follicle GCs or oocytes that activates the primordial follicle. FSH and LH stimulates an mTOR expression to manipulate somatic cell proliferation and steroidogenesis. E2 stimulates in mTOR expression to promote protein and DNA synthesis, but P4 inhibits the DNA synthesis through another pathway. So this is mTOR in endometrium. So now the impact on the AMH and AFC. So friends, as we all know, the AMH and AFC increase. AMH role in recruitment of the primordial follicles. Absence of AMH diminishes the primordial follicle pool. AMH is involved in initial follicle development, and serum AMH level correlates with the ovarian follicle number. So there is a study in the NCBI PubMed journal regarding the favor of this role of mTOR signaling in female reproduction. So this is a very interesting study. Any one of you can get on the net. A role of mTOR signaling in the female reproduction. Regarding this mammalian target of rapamycin mTOR is conserved for the serine threonine kinase of the phosphatidylinositol kinase related family that regulate the cell growth, metabolism, and autophagy. The earlier what the mechanism of action, that all is supported by this journal. So this all have supported that this has been used to improve for the reproductive diseases like premature ovarian failure. Even in the PCOS and endometriosis patient also they have presented the studies, but more studies, because I have searched a lot of journals yesterday while making this presentation. So more of the studies in the favor of the treatment for the premature ovarian failure. Yeah. So the data in the Indian patients, dear friends who have joined from other countries. So friends, I am presenting some data in the Indian patients with leucine in the poor ovarian reserve. So the studies have been presented. In this, they have shown the change in the ovarian response and the embryo quality after the 90 days of L-leucine therapy in the poor ovarian response patients undergoing the controlled ovarian stimulation. So minimum 3 months treatment is advised. So there are a lot of studies, and the preparations are also available in the market of the 800 mg. The studies have shown the mean AFC was before treatment and after treatment is improved from 6.9 to 8.2. Average oocyte number is also increased, and total metaphase to oocytes also increased. Average number of day 3 cleavage and grades A embryo before and after treatment was also increased. I'm so sorry to them. The mean AMH before the treatment, I'm so sorry, I'm not able to speak. For a poor, the studies have shown the statistical significant increase in the AFC, oocytes retrieved, and number of grade A embryos. For a poor responder, one extra oocyte or embryo could increase the chance of the pregnancy and possibly avoid the donor egg program. 800 mg of L-leucine daily provides a good results. So lot of studies in the favor of this. So now coming to the other drug is the DHEA, which we all are using. A lot of studies in the favor of that also. DHEA supplementation can increase the expression of AR in the pre-ovulatory, in the GC, and both in vivo and vitro. So a lot of studies in the favor of that also. The studies have shown with this DHEA supplementation, increase in the FSH receptor expression, follicular atresia, follicular growth, insulin growth factor, increase ovarian response, ovarian reserve cycle, oocyte quality and embryo quality. Friends, I will wind up within few slides. Sorry, it's very bad throat. I'm not able to speak much. This dehydroepiandrosterone acts as an adjunct to the gonadotropins in infertility Indian women with premature ovarian aging. A lot of studies have been presented in the favor of this. So this we all aware regarding this DHEA. So now regarding this mitochondria in the female reproduction, the production Friends, I've put my YouTube detail ID on the chat box. Those who are having the question, the program is going live on the YouTube. You can put your questions there. I will reply later on. Now I'm not in a position to reply much. I'm quickly winding up the presentation. Whatever the queries you can put in the YouTube, I will try to reply everyone. So, lot of studies in this diminished ovarian reserve has been associated with reduced mitochondrial DNA count. In the mitochondrial DNA, normal women age 20 to 30 more than 3 lakhs, in while in diminished ovarian reserve in less than 1 lakh. Now, this coenzyme Q10 increases the energy production, reduces the cytoplasmic fragmentation, oocyte quality, embryo quality, improves the embryo cleavage and pregnancy outcome. Aging of the female germ is accompanied by the mitochondrial dysfunction and reduced ATP levels. So, a lot of studies for the favor of that. Besides this, the other drugs what are available is the L-citrulline. Lot of studies that how L-citrulline is acting as a nitric oxide donor, and which also help in giving the good follicles, improves the L-arginine, nitric oxide and nitrates, which is giving the better ovarian response and better pregnancy rates. So now the question comes regarding this melatonin also. So this melatonin, ovary specific antioxidant, ovarian free follicular fluid, concentration of the melatonin is 3 times higher than the serum. It improves the superoxide dismutase and glutathione peroxidase activity, significantly decrease the biomarker of the damage. So a lot of studies have come with the use of this melatonin. Again, the studies have come regarding the use of this vitamin E and astaxanthin. Good results with the use of the vitamin E. And regarding this astaxanthin, also a lot of studies have come in the use of the patients of this poor ovarian reserve. While this with vitamin D3 also, yes, these days we are using this vitamin D in all the patients and getting the very good results. So now in 2 slides, I will cover this growth hormone. Yes, we all know the growth hormones, but it is very costly. Personally, I am not in a favor of growth hormone. Cost is also one of the factor, plus not very good results. If even though we increase the cost therapy of the patient, but results are not as dramatic. Yes, some are using this neostigmine also, but I am also not in a favor of that also. So I personally using this coenzyme Q10, melatonin, now leucine also getting a very, very good results, and nitric oxide donors too. Yes, the corticosteroids also. The studies have come regarding the use of the dexamethasone 1 mg per day orally till retrieval. Lot of the studies by the different authors. Now this study, the different things which has been recommended: antagonist, microdose player, long protocol, LH, letrozole, FSH antagonist, DHEA, short protocol, transdermal testosterone growth hormone, HCG added at stimulation. Because poor ovarian reserve itself can take 2 to 3 hours of class. So completing in half an hour is little difficult. This slide I have taken from my big brother, Dr. Abu Bakar's presentation. A great teacher. All things has been covered in this presentation. So this slide, he told me that this slide is having all the in this. So increase in FSH dose, CC and FSH HMG antagonist, luteal FSH start, estrogen for luteal support, follicular flushing, long stop protocol, FSH HMG, FSH dose 300 or the late FSH starting or metformin, ultra short antagonist, modified flare, low dose aspirin, natural cycle. Lot of protocols has been recommended. FSH dose 450, FSH dose 600 or the CC. So the epiphany is the diminished ovarian reserve frequently results in the poor response to ovarian stimulation, as I already mentioned. However, the poor responder is not always someone who has a diminished reserve. So with this, friends, I will like to wind up today. Those who are having the queries, so please drop in the YouTube chat box. I will try to answer each and every one. Anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. A famous quote by the Henry Ford. And again, I am finishing my talk, giving again tribute to my great friend, Dr. G.K. Tripathi. So thank you all of dear friends for having your time and attention. Once again, I am putting, I already post the link in the YouTube. Once you go, आप जाओगे तो आपको उसमें दिख जाएगा. There you can see those all who are having the queries can put the there. I will try to answer each and every one. So with this, I will wind up for the today. Sorry for the bad throat. I'm not able to speak more. Arpita dear, sorry, I have to wind up today.
No, ma'am, thank you so much. In spite of having bad throat, you conducted it very well. Thank you so much for that, ma'am.
Okay, dear. Okay, yeah. Most welcome, dear friends. Please drop your message on the YouTube. I will try to answer everyone.